Dr. Woreta received her medical degree from the Johns Hopkins University School of Medicine and her MPH degree from the Johns Hopkins Bloomberg School of Public Health. Following an internship in internal medicine at the Johns Hopkins Hospital, she completed her residency in ophthalmology at the Wilmer Eye Institute. She then completed a fellowship in cornea and refractive surgery at the Bascom-Palmer Eye Institute at the University of Miami. Dr. Woreta returned to Wilmer to join the faculty as Assistant Chief of Service and the Assistant Director of the Eye Trauma Center at Johns Hopkins in 2013. She's currently an Associate Professor of Ophthalmology, the Eugene Dewan Professor of Ophthalmic Education, and the Vice Chair of Education at Wilmer. She also serves as the Director of the Eye Trauma Center and the Ophthalmology Residency Program Director. Her clinical and research interests include complex cataract and corneal surgery, ocular trauma, medical education, and quality improvement in healthcare delivery. Everyone, please welcome Dr. Woreta.
Thank you so much, Ruthie, and thank you everyone for our students from Hopkins for organizing this virtual curriculum. As Ruthie said, I'm the residency program director for the last 5 years at Hopkins and recently took over as the vice chair of education. So I'm going to give an overview of a day in the life of a cornea specialist and an educator. And so thanks for putting your name and your year in the chat. I just want to see how many MS1s and MS2s, MS3s and 4s we have. So, and then I'll talk for maybe about half the time, and then we'll have plenty of time for questions. And it seems like we have a wide variety of years. So again, we can answer questions starting about early exposure to ophthalmology versus the application. So we'll cover the whole gamut. So basically, for those of you who are MS1s, ophthalmology residency is a 4-year endeavor. And basically, it's 3 years of ophthalmology and then 1 year of an integrated or joint internship. So this is our 4th year of the integrated internship or joint internship. Before, we used to have it where you would do your preliminary year at the institution or another institution and then come for the ophthalmology. But now everything's done pretty much at the same institution, which is nice because residents get to hit the ground running. They know the hospital system, the EMR, and so forth. So that was one of the main reasons that we changed that. And in that integrated or joint internship, you get 3 months of exposure to ophthalmology, which is another benefit of that. So there are really no programs left with the preliminary program anymore. Maybe there's one or a couple out there, but pretty much most of us are integrated or joint. In terms of fellowships in ophthalmology, it's actually quite diverse. So for those of you who are undecided about applying in ophthalmology, ophthalmology is a field in itself where there's many different specialties, both surgical and non-surgical. So for those of you who like surgery, there's some heavy surgical fields like surgical retina, oculoplastics, anterior segment specialties like glaucoma and cornea, pediatric and strabismus. You do a lot of surgery on the eye muscles. For neuro-ophthalmology, it's actually can be surgical if you'd like, and it can also be medical. But for example, a lot of people who specialize in neuro-ophthalmology do oculoplastics procedures. In terms of orbit surgery, they can also do strabismus surgery. And some people actually do double fellowships in, for example, neuro-ophthalmology and oculoplastics, which goes well together. We have uveitis, and there's medical retina, which kind of sometimes go together. And uveitis you can do surgeries like cataract and other anterior segment procedures, and you can do injections, for example, in medical retina. So again, a lot of places will have either medical retina combined with uveitis fellowship versus strictly uveitis. And then finally, pathology, which is sort of not as common, but for those of you interested in pathology, you can go either the ophthalmology route and be an ocular pathologist, or you can go the pathology route, mostly neuropathology, and then become an ocular pathologist that way. And there's a great need for that because we only have a handful of those in the country. As a cornea specialist, I do mostly cataract surgeries, and then I do some other surgeries such as using intraocular lens exchanges or secondary intraocular lens fixation when there's not enough support to do your normal cataract surgery with. You can also do refractive surgery as part of your cornea practice, and then cornea transplants. So in terms of the cornea, for those of you who are not familiar with cornea surgery, these are the 5 layers of the cornea that you can see here. And the nice thing about our surgeries is it's really evolved over the last decade, where we're doing more and more lamellar procedures, which are not full thickness. So you can see in the graph B here, this is a full thickness transplant where you change all of the layers. That's called a penetrating keratoplasty. And that used to be the treatment of choice for diseases such as Fuchs' corneal dystrophy or pseudophakic bullous keratopathy, keratoconus, but we've really evolved now towards more selective transplantation, which is great because patients get more a faster visual recovery. They have less risk of rejection, and it's more tectonically strong. So that, for example, if your patient has trauma, if they've had the full thickness transplant, they're more likely to lose the eye with the trauma. So moving on from the penetrating keratoplasty, you can see we have something called anterior lamellar keratoplasty, which you can see here. So you're basically transplanting the anterior portion of the cornea. And in D here, you can see this is a deep anterior lamellar keratoplasty. So then you're transplanting 95% of the anterior surface, leaving intact Descemet's membrane and endothelium. So why would we use a dog? Now this is becoming the treatment of choice for keratoconus, which is a corneal ectasia. So again, before we used to do full thickness transplants, but now if you do a DALK, what you can do is, again, you eliminate the risk of endothelial rejection because the patient has their own endothelium. And again, if the patient has a trauma, they won't be as likely to expose their intraocular contents as they would with the penetrating keratoplasty. And then for endothelial disease, such as Fuchs' corneal dystrophy or pseudophakic bullous keratopathy, which is basically when you get cataract, when you get swelling after cataract surgery, basically the endothelial cells, which are shown here, are responsible for pumping all the water out of the cornea to keep it crystal clear. So when you have dysfunction, you get swelling of the cornea and it affects patients' vision. So you can selectively replace the endothelium as shown here. In a Descemet stripping automated endothelial keratoplasty or DSEK, you are replacing the endothelial layer with a little bit of stroma. So those grafts are typically from anywhere from 60 to 80 microns. And then in the newest kind of endothelial transplant, the Descemet's membrane endothelial keratoplasty or DMEK, you're just selectively replacing the endothelial layer as shown here, and those grafts are around 10 microns. So it's an exciting time in cornea in terms of the evolution, and I think in the near future we'll probably be injecting endothelial cells and not doing transplants, but there's a lot of research into genetics of corneal diseases as well as different gene therapies for treatment, and also again less and less invasive methods of corneal transplantation. So if you had Fuchs today versus 20 years ago, your treatment will be different. Before you would get the full thickness transplant, and now you'll get the DMEK, which is now pretty much the standard of care for Fuchs, and your recovery time and everything for your patients is much faster. So I mentioned that sometimes I will do secondary IOL surgeries, for example, or intraocular lens fixation when patients lose their normal support for cataract surgery. So you can see here, I'll show a video of this patient. You'll see their native lens moving, so that's abnormal. And basically that's called phacodenesis. And you can get phacodenesis or zonular weakness for a number of reasons, including Marfan syndrome, trauma, can be associated with diseases like homocystinuria. But you can see this lens is quite unstable. So this is retina coming in and putting in vitrectomy ports. So again, for those of you who like surgery, surgical retina is very beautiful, and you can see it's a very delicate surgery. You can see here the lens has actually fallen onto the retina, and our retina surgeon is picking it up and using the fine vitrectomy instruments to basically pulverize the lens. As you can see here, you can see they're carefully eating it, removing the vitreous jelly to reduce the risk of retinal detachment, which in patients, for example, with Marfan's is pretty high. So this is me now coming in, and you can see now the patient has no normal support for cataract surgery, for putting a lens in the eye. So now I'm using Gore-Tex suture to secure the lens in place. So you can see I'm folding the lens, inserting it through the corneal wound that I made, And then after I insert the lens, you can see I'll use the 4 strings to center it and fixate it to the sclera, which is the white part of the eye there. So you can see I'm externalizing the sutures and then tying them with the surgeon's knots you'll learn in surgery, which is a 3-1-1. And then you can see how the lens is perfectly centered, and then you secure it in place with these sutures. So again, for those of you interested in surgeries, anterior segment surgery is pretty delicate. And the nice thing about it is you get pretty quick results in terms of visual recovery from cataract surgery or corneal transplant or surgeries like this, where the patient within a week will be seeing much better. And then you can see the retina surgeon, the last step is for the retina surgeon to remove the ports, and then we close the conjunctiva, or which is a peritomy that we performed with small sutures. So when you're doing your general surgery, you generally work with large sutures. In ophthalmology, we work with very small 10-0 or 8-0 sutures, as shown here. So this is another case of a patient that I was doing cataract surgery on. This was a 14-year-old who went off to camp for the summer on the West Coast, and then on the first day had an open globe injury where she basically something sharp hit her eye. She went to California. She was in California, so she went to a teaching hospital there, and you can see they did a beautiful job of suturing her cornea. You can see those fine little 10-0 nylon sutures, and then she developed a traumatic cataract and came to see me in Maryland. So you can see here what a traumatic cataract in a young patient looks like. I'm using this dye called trypan blue to stain so I can visualize the capsule, and you can see there's been an opening from where the injury was. And then basically in a 15-year-old, it's very soft, the lens material. So you can see I'm using 2 little instruments called irrigation and aspiration to aspirate the lens material, which comes out pretty easily. So you can see in this case, I decided to leave the patient without a lens initially so that I could get good measurements. And then a couple weeks later, I went back, and you can see here, she does, unlike the patient I showed you first, she does have a scaffold that I can put the lens in, which is called the sulcus. So you can see me injecting the lens, and she ended up doing very well. Again, I'm putting in a corneal stitch with 10-0 nylon. And I think right now she's about 20/40 uncorrected, and then with correction, she can get to 20/20. So again, pretty rewarding to take her from when she presented at hand motions to, 20/20 with correction now. And so as a cornea specialist, in addition to doing lots of surgery, there's also medical cornea. So there's this whole ocular surface disorders like Steven-Johnson, Sjogren's, that you can specialize in. And there's lots of new medications out there for treatment of these ocular surface disorders. You can treat infectious corneal ulcers. There's also corneal dystrophies and degenerations, and then neoplasms of the conjunctiva and cornea, which we take care of. So, for example, you can get CIN in the conjunctiva or cornea, so ocular surface squamous neoplasias. You can also get melanoma in the conjunctiva. So, as cornea specialists, we do treat those either surgically with removal, as well as medical therapy with drops like bifluorouracil and topical mitomycin. So there are some emergencies that we deal with in cornea. Fortunately, they're not many, but this is a patient who came to the ER after working in construction, and you can see this is probably one of the most rewarding things to take care of, because the patient comes in with a lot of foreign body sensation every time they blink, and you can see this foreign metallic body right here in the cornea. Fortunately, it's just in the superficial cornea, so you can easily remove it using a 30 gauge needle. You can use what we call a corneal burr to smooth out the rustring that's often left by the foreign bodies, and the patient will love you because you give them some relief. We also treat ulcers, not infrequently. So the most frequent cause of corneal ulcers that we see as cornea specialists is contact lens associated, 9 times out of 10. So you can see this was a patient I took care of with our residents who was sleeping in her soft contact lens wear. And you can see when she presented to our ED, she had a complete melt, basically, where she has a large soupy ulcer You can see the white infiltrate, this ring, and most of the time in patients who are contact lens wearers, it's Pseudomonas. And unfortunately, Pseudomonas, just like in other areas in the body, like the lungs, it can be a bad infection. So basically, if you have a patient with who's a soft contact lens wearer who starts with a small ulcer, you really want to treat them urgently with every hour fluoroquinolones to make sure that it doesn't turn into this. You don't want to undertreat, for example, with 4 times a day topical. All right, so that was my talk on the cornea aspect in terms of what I do. So generally, I operate about a day and a half a week, and then I see patients about a day and a half. And then for 40% of the time, I usually dedicate that to educational endeavors. So in terms of my role as a residency program director, I'm going to talk a little bit about switch gears and talk a little bit about applying in ophthalmology specifically. So we are one of the only specialties to use the San Francisco match system. So we don't use ERAS or the NRNP like medicine and other specialties. I think urology and ophthalmology are the only ones who use the SF match. So we have about 120 ophthalmology programs in the US, about 460 positions. And the match rate for seniors, for US seniors, is about 80%. So and then you can see that the timeline for the application, we're an early match. Again, we're one of the few specialties who are in the early match with urology. So that means that you match prior to the NRMP match, which is usually in the spring. So for ophthalmology, you want to know that you need to apply earlier than your other specialties. So the target deadline is September 1st. And then some programs have other internal deadlines, but usually it's not sooner than September 1st. One bad thing about being in our own match system is that we don't have a couples match within that you can match, for example, with someone in medicine or surgery. So that's a disadvantage for sure. But the good thing about the early match is that because it occurs before the NRMP match, you can still strategize. If you have a significant other, you can still strategize their match list. Now, if you're applying with someone in ophthalmology, we actually just in the last 2 years have a way to indicate that you're matching with a significant other in ophthalmology within the same match system. So that was definitely a positive. And so this is the timeline for the seniors on the call. This is the time that I know you're familiar with this already, but you can see the timeline. So basically, on September 3rd is when the applications are released to programs, and the SF match application opens on July 1st, and then we get the dean's letters in September 25, which is a little earlier, which is good. And then the first date that we can extend interviews starts in October, the beginning of October, and then we can start interviewing on the 22nd of October. Now, one thing about ophthalmology is that all the interviews are virtual so far. This is our 4th year of all virtual interviews, and there's pluses and minuses of it. But I think the pluses outweigh the minuses in that the cost of interviewing at 15 programs, let's say, which is the maximum number you can apply for an or you can interview for an ophthalmology, is enormous. So this really, by having it virtual, really is less of a burden on applicants. Now, because of that, our specialty society, the American University Professors of Ophthalmology, did make it so that you can visit programs in person, which is great for the applicant. So there is a period of time after we submit our rank list, but before the applicant submits the rank list, that you can visit a program, which is great because, if you're going to spend 4 years in a city or an institution, it's good to visit it. So there is a period of time between January 4th and January 25th before you submit your rank list where you can visit all our programs. And each program usually hosts their own open house. Not 100% of the programs do it, but most do. And again, that's a way to sort of allow in-person visits and then decrease the stress because we've already submitted our rank list. So it's really a low stress opportunity for applicants. So you can see here, we stop interviewing by December 20th, and then the rank list for the programs is due by January 3rd. I think we're the only specialty that separates the rank list submission for the applicants and the programs, which again is to the applicant's advantage. Then we can have your open houses, and then the applicant rank list is due on January 28th, 3 days after the open house concludes. And then we release our match results on February 4th. And then I think the NRMP match is in March. So you have some time to think about it if you're applying with a significant other. And so just some data from the statistics I mentioned. The match rate for the seniors is about 75%, 75 to 80%. And then you can see if you graduated and the match rate does go down. And then for DOs, any DOs on the call, the match rate is less for DOs. So it's 30% for the seniors, and then for the graduates a little bit higher, or double, so 67%. And then for international graduates, it is lower at 34%. So you can see here for the step 1 score, you can see this is old data because the step 1 score is pass fail, but just it's about this for step 2. But you can see the average for the matched applicant is 247, and what we're seeing is pretty similar things for the step 2 score, but that data is not released yet. And so, but you can see for the unmatched mean, it's 237. So definitely a good step 2 score can help you. So in terms of ophthalmology at Hopkins, what we look for at our program specifically is, we are an academic medical center, so we do look to train leaders in ophthalmology. So we do look at research. I think all programs like to see good clinical grades, especially in sub-internships, when possible, to get honors on those. And then there is a autobiographical statement for 500 words, as well as some questions that they ask you to answer in terms of how you demonstrated resilience, what values would you bring to a residency, etc. The interview shouldn't be underestimated because it's quite important, because once you get your foot in the door for the interview, I feel like that kind of equalizes many of the applicants, so the interview performance can help. Now, again, it is sometimes challenging in the virtual setting, so you want to make sure to prepare for that so that you're not caught off guard in terms of not being there in person. As I mentioned, the step 2 score we do find is important, so you don't want to write it off. We do in ophthalmology have a focus on holistic screening, so if you don't get a 90th percentile step score, you don't have to think that you can't enter ophthalmology, but you're just going to have to shine in other areas, for example. And then letters of recommendation, we basically need 2 letters of recommendation from ophthalmologists, and then 1 from usually a sub-I or something to attest to your clinical skills in medicine. So for the contacts for our program, you can see myself, and I'll put my email in the chat, but I'm the residency program director, and then Dr. Jampel is our medical student educator. And I have 2 associate residency program directors, Dr. Amanda Henderson and Dr. Michael Saluski. And we have an assistant chief of service who is a fellowship trained or generally fellowship trained or comprehensive ophthalmologist who comes back and spends a year dedicated to working with our residents, and they do all the trauma with them and serve as the assistant director of our eye trauma center. So that's all I have about for sort of prepared slides. So I'd like to open it up to questions in the last half an hour that you have, either about anything about ophthalmology, any specialty, as well as any education related things for anybody interested in sort of the path to being a program director or an educator. That's been my path in ophthalmology, so I'm happy to answer any questions about that.
Thank you so much, Dr. Woreta. That was an excellent talk, as usual. So the way that these question sessions go, if you all don't mind just using the raise hand feature, and then we'll go in order of how they pop up on the screen. So if anyone has...
I have a question. I do see a question about signals. I didn't mention that, which I meant to. So thanks, Mariam, for mentioning that. There's 2 things I didn't mention, which I want to mention. So yes, ophthalmology for the first time is rolling out signals, which other programs like ENT have had for a while, as you may know. So for the number of signals we have, it's 7 signals. And so that's a low number. So you really want to be strategic in using your signals, since you only have 7 of them. So you don't want to, for example, signal only top tier programs, for example. You want to have a good mix. You also want to talk with your advisor about what for you looking at yourself as an applicant in terms of what type of programs you should signal. There is a question about whether you should signal your home program and away programs, and our SF match has basically said yes, you should use signals for those. So that's they want to make it equitable for those, for example, without home programs. So they say that you should signal them, but basically it shows strong interest. Now, if you don't signal the program, you could still get an interview, but again, it does show a strong interest. And one thing about the ophthalmology is that you can personalize your personal statements for programs. So even let's say you can send a signal because you're out of your 7 signals, you could write a statement about why you're really interested in, for example, Hopkins, and you can actually send a different personal statement to every program that you apply to. So that was a good question about signaling. I think it will help. 7 is a little bit low for number of signals, so I know it's going to be a little bit stressful for the applicants, but again, just speak with your advisors and that should help. And then one thing I didn't mention, which I meant to on my talk, was about the new research program we have at Hopkins for those of you interested in an academic career. We have a new research path called the STAR. So when you go to Hopkins to apply, there'll be 2 programs. One is our standard 4-year program, and one will be the STAR, which is funded by the National Eye Institute, and Wilmer we'll know officially if we're being funded by the NIH in the fall, but it's looking promising. So we'll basically have, so we're either, we're going to definitely have this for this coming academic year, but basically for those of you interested in doing a research year in addition to the 4 years, then we'll be offering that. And that will be after your PGY 1 year, where you can take a year off and do research with a faculty member, and then that will be sort of the basis for the rest of your academic career. I see another question in the chat from Morgan about if our school does not have a sub-I, advanced elective or sub-I in ophthalmology, is there a preferred specialty we should try to do? And is it, but Morgan, do you mean an advanced elective or? I think I know the question about sub-Is. So, acting internship, got it, perfect. Yeah, so yes, actually, we don't really look for the sub-I in ophthalmology specifically, because you'll have like other electives, and we look for a sub-I in internal medicine or one of the core, so either surgery, internal medicine, pediatrics. So I would definitely recommend that for anyone applying in ophthalmology. I mentioned the joint and integrated internships. Most programs are integrated or joint with internal medicine, so that's certainly a popular one. But then there are a couple like Vanderbilt and UCSF that are integrated with surgery. So you could do what you love, and I think it doesn't really matter which one you do, but they do want to see that you you want to see that a great grade in the, like, I think the difference between your sub-I and let's say the other clerkships, which sometimes are pass fail, is for the sub-I there's no shelf exam, so the grade is really based on sort of your performance and taking care of patients over the month. So people really look at the sub-I grade. So you don't want to get a pass on your sub-I, and then if possible go for the honors, and just think about it as it's sort of a reflective performance on how you'll be as an intern. So we like to see them again in things outside of ophthalmology. And I think the reason for ophthalmology, I mean, it is, as a medical student, it's difficult to kind of have the clinical expertise to do a sub-I in ophthalmology. I mean, you could do one, but we also like to see one in medicine and surgery where you're really able to get in there and take histories, and so that's why we like to see that. Plus, people do want to see how you'll do sort of with the patient care aspect and relating to patients, which again is I feel like easier with medicine and surgery.
So it looks like Quentin had his hand up.
Yes, thank you. I had a quick question about how many away rotations people will do for ophthalmology. And then a follow-up question is it becoming more common to do research years for ophthalmology, because it's becoming more common in fields like ENT and ortho?
Yes, and like neurosurgery, I think. But yeah, I would say for aways, we're actually not that heavy on aways in ophthalmology. So I know there's some like in neurosurgery, apparently you have to do several. It's definitely not like that in ophtho. I tell my students to do aways when they really have a focus on a specific program. For example, if they need to match in the Boston area, then I would say go ahead and do your aways. Now the aways, people always say they can hurt you or help you, so it is an audition. So you can't have a bad day on the aways. So we want to make sure you're going to impress. And I would say it can definitely help, and I've definitely seen my students match at places where where they have done aways at. The other thing, if you don't have a home ophthalmology program, then you definitely want to do aways because and get that exposure. But again, it's not, and I definitely overall you'll be more likely to get an interview and match if you do an away. So it definitely can be a useful tool. That being said, it's not like other specialties where you have to do one and you have to get letters from aways. Like we don't have anything like that in ophthalmology. And then what was your second question again?
My second question was, is it becoming more common to research years?
So good question. I mean, I think we definitely have always looked at research in ophthalmology just because it is a competitive specialty. So basically, I think it is being more with step one being pass fail, and then the clinical grades being mostly pass fail as well. I do think there is a little bit more emphasis on research for sure, and especially for academic programs like for example Hopkins. But we've always sort of had that research focus. So the question about whether you need to take a year to do it or not is the question. So a lot of times, somebody will, MS3, for example, will come to me and say, this is what I've done. Do you think I need to take a year off? So it can be personalized. Now you don't need, some students are like, oh, I need 10 papers, and you don't need all that. Like this is not a faculty position, but you want a couple of projects that you scholarly projects that you've worked on. It can be in anything, it doesn't have to be, it can be in education, it could be, clinical projects, it could be. So, but whether you want to take a year off or not really depends on, when you got started, as well as, again, we have a lot of meetings in ophthalmology. So that was another thing I didn't have a chance to mention, but there's so many medical student friendly meetings in our field. A lot of us just got back from moving in ophthalmology. There's ARVO, there's the American Academy, there's all these different subspecialty meetings. So there's definitely lots of opportunity for med students to present. So you want to have a couple presentations and then a couple papers. Again, they don't need to be 10. And so whether you need to take a research year or not will depend on, if you've done no and you want to go to a program where, it's highly academic, then you could consider a research year. And there are different opportunities at different med schools for the research year. Some of them become funded. For example, at Hopkins, we have a dean's year, and a lot of people have apply for it. There's also Research to Prevent Blindness. For those of you who are interested, a year off is a very competitive grant that medical students across the US can apply for and take a year that's funded. So it can be a great opportunity. It's definitely not necessary. And again, I would probably speak with your advisor to see whether it's necessary or not. Some people do masters in public health or other kinds of master degrees as well. I would say though, because it is a competitive specialty, for example, when I was MS1, I wasn't sure if I was going to go into ophtho or not, but I had exposure just by one of our medical school functions where we just meet with the faculty. And so that summer I did decide to do research in ophthalmology. So if for the MS1s on the call, if you are interested in ophthalmology, then I would try to pursue research early on, so that, I mean, if you end up going into medicine, it won't hurt you, and you don't necessarily need all the research for medicine. But that's why, if you're interested, I would encourage exploring it early on, so you have plenty of opportunities and don't need to take a gap year if you don't want to.
Okay, next we have Ari.
Yes, thank you so much, Dr. Woreta, for an amazing presentation. My question is, besides taking a research year, what advice would you give students who are applying from schools that don't have ophthalmology residency program?
So Ari, that's where you want to do the away rotations, definitely. And you want to, the aways, they are competitive in terms of, there's a lot of students who apply. So you want to do it early and plan it out. So I think for programs, if you're from a program without an ophthalmology residency, then definitely look, like Ari spent the summer at Hopkins with us and definitely took advantage of going to the OR and working with different research faculty. So look for a lot of schools like Michigan, Hopkins, Mass Eye, they have programs for rising MS2s where you can spend a summer getting exposure. So definitely look for those programs if you don't have one. And then when you get to your third year, definitely strategically plan which electives you want to do so that you don't miss deadlines, because sometimes, again, if you're applying sort of at the last minute and then, there's a lot of other students, then you're not going to get it. And in addition, your rotation schedule, you kind of have to organize it so that you have time to do away. So make sure that you plan that accordingly.
Great. Keyshawn?
Hi, Dr. Woreta. Nice to see you again. I was wondering if you could speak a little bit about why you decided to kind of go into academic ophthalmology. Obviously, there's many paths. You can go into industry, do a little bit of research, also private practice. So,
Yes, good question about academic ophthalmology. So I would say about half of my residents may go into private practice and half into academics. So I think those interested in academics, it does really matter where you train. So I did my medical school and residency at Hopkins, which is highly academic. So I really didn't consider private practice when I went to the job market. I sort of knew I wanted to be in an academic center based on where I trained. So, but again, half my residents end up doing private practice, which is, there's nothing wrong with that. So you want to kind of understand the landscape. Now, the landscape has changed a lot since over the last decade. So, for example, private equity is now on the scene. I mean, this will affect all our specialties, but for ophthalmology, for example, the private practice setting is not the same as, for example, when I was a resident, when there was no PE. So there are definitely advantages and disadvantages of working for private equity. And so we do find that at academic medical centers, they're also changing dramatically in terms of the landscape. So there are all these clinical paths that weren't there back in 20 years ago, in terms of you can come to Hopkins and work mostly doing clinical work, 80%. So there's definitely more flexibility in terms of, you don't have to be on an NIH grant or to be at a place like Hopkins anymore. You can see patients and do surgeries. For me, I always liked, so when I came back, I did my fellowship in Bascom Palmer and Cornea, and then I came back to Hopkins to serve as that assistant chief of service that I talked about during my talk. That year, I had a year to spend with the residents, and I really realized that I love teaching. And then right after I finished my chief year, I became associate residency program director for 5 years, and then PD. So I think for me, what kept me at Hopkins in academic ophthalmology was the chance to be an educator. So you can find your niche in academia, whether it be education, basic science research, or any other clinical research or clinical trials, whatever you want. You can sort of find your niche in academia. We have a tripartite mission, as you all know, in terms of research, education, clinical care. And so I like the balance. So I mentioned I'm sort of 60-40, where I take care of patients and do surgery 60% of the time, including teaching. And then the other time I have just time for program development in terms of our residency program. So it gives you a lot of flexibility. I like working in an academic setting where there's a lot of collaborators and colleagues. So there's a lot of advantages to being in academia. And if you're at a large institution like myself, I do think there's a lot of opportunities for collaborations among different schools. Like we have a School of Engineering, School of Public Health. I just started taking classes for my MBA, so that is covered by Hopkins and some of the faculty there. So lots of advantages to being in the academic setting. And then the private practice, most private practices are focused on clinical care, but there is some flexibility in terms of a lot of people in private practice can do clinical trials quite easily. So we have some of our former residents really active in terms of innovation and private practice. And then we do have some residents who go fully into industry and maybe see patients like once or twice a month, for example, working at Genentech. And so there's just so many different paths that you can take in your career in ophthalmology.
thank you for sharing.
All right, next we have Fasika.
Thank you. Hi, Dr. Woreta. Question for you.
Jessica.
Hi. question for you regarding the application, considering it's coming up soon. So I was trying to look at the how many programs to apply and just figuring out how to narrow that. I know that oh, sorry, it says we'll lower your hand. I got a notification. It says that I know that the average is quite high, around in the mid 80s. Do you have any advice for how to narrow our list from the 120 to like mid 80s or even lower?
Yes, good question. So yes, I mentioned there are 120 programs. So I do think that the number of programs you should apply, we've seen application inflation across the board in all specialties. So applicants are applying to more and more programs. But I think the best way to decide how many to apply to is meet with your advisor. Now, you can have different advisors at your medical school, including from the dean's office, but then you also have a residency PD at the program if you have an ophthalmology program, as well as usually a medical student educator or clerkship director. So I recommend you meet with both of those people because we both have knowledge, and I see it from like the residency application side. And so I would say generally 50 is enough, but then you want to make sure to have a good variety of programs. So sometimes you see sort of apply to all, top tier programs. So you do want to have your top tier, middle, and a couple of safety schools, and then apply sort of geographically. I think the signals will help in terms of reducing the number of applications maybe that applicants feel like they need to apply to, but I would say, generally 50 is enough if you plan it strategically versus the 80. Now, let's say, you have some challenges like I mentioned international graduates have a lower match rate and also DOs, or let's say you didn't pass step 1 on the same, then you might want to broaden it and then apply to more of the programs, like sometimes if, or a reapplicant, for example, we know that reapplicant match rates are lower. So then I say, go ahead and apply to every program, just in case,
Thank you.
All right, Marina.
Hi, thank you for your talk. I was wondering if there's any benefit or disadvantage in having 3 ophthalmology letters as opposed to 2 ophtho, 1 surgery or medicine.
Okay, Marina, yes, I saw your question in the chat. So, well, generally we say 2 ophthalmology and 1 medicine. And the reason we say that is because, as I mentioned in my talk, it's really hard to wow an ophthalmologist with clinical skills because it's so specialized. So we really want to see, we want to see the other side in terms of, your clinical, your ability to sort of take care of patients longitudinally, present. And again, sometimes in ophthalmology, you will get the opportunity to work in the OR or the clinic. But again, the student's role in ophthalmology is a little different. So we really want to see that, and in addition to the fact that some of the joint and integrated programs like to see the medicine or, the surgery performance too. So, but that being said, if you have 3 opto letters and one of them is clinical and, talking about how great you are with patients, how helpful you were in clinic, then that will be fine too. But what you don't want is like 3 research letters, none of which attest to your clinical capabilities or, sort of bedside skills or bedside manner.
Thank you.
All right, so since Quentin asked a question already, I'm just going to take one question from the chat and then we'll get you. Okay. All right. So one of the questions was, how do we know if we're competitive for a certain program, as SF Match does not release average board scores per program? My school does not have an ophthalmology advisor or home program.
Yes, good question. So, I mean, on average, I had mentioned it's about 245 to, for the average step 1, which again, we looked at this with step 2 data, and it's similar to that. That being said, I mean, I usually tell our students in optho for board scores, like above 250 is excellent, between 240 and 250 is solid, and then below 230 and 240 is below, a little bit below average, but still. But then once you get below 230 in optho, that's where there has to be something that is off, something really strong elsewhere in your application. I mean, we have had students who match with scores in the 220s or below, but again, you really have to show your strength, whether it be in research or in taking care of patients. So I would say that, well, back maybe when I applied in 2007, like there was definitely kind of strict cutoffs for board scores. And I think a lot of the programs realized that, just because you got a 270 on your step one doesn't mean that doesn't translate necessarily into being a great resident. So they definitely look at, so there's been a big focus on like holistic review in terms of looking at other things besides these metrics of just one score. So again, if you're strong, it's sort of, you just have to have your strength in other places and demonstrate that. One thing that residency programs can be concerned about is your ability to pass the boards, which as a program we do, like ACGME monitors our board pass rate. So that's where programs, if the board score is too low, can get a little concerned about that. But I would say overall, I've definitely seen it in our organizations, our AUPO, over the last 5 years, the big push towards more holistic screening. So you want to use your essays to kind of describe, things that make you stand out in terms of resilience, your ability to work in teams and other things that might show, some other characteristics that we're looking for.
Great. And then Quentin, you can.
Oh yeah, and I didn't really answer the question actually about for certain programs. I mean, the thing is, yes, you kind of have to, you won't know, we don't release the average of the scores, but so you're sort of, again, if you sort of want to meet with your advisor and look at the competitiveness of your overall application, taking into account your score too, to see like, where's a realistic place for you to match. So yes, I think all of us though, even at top institutions, like we've definitely taken applicants with a little bit less than average board scores if they shined in other places. So just make sure you have a well-rounded application.
My other question that I had was, what opportunities are there for doing like service in like rural and underserved communities, both nationally and globally?
Good question. So I think, and we have our Hopkins members who do a lot with our with the program called Vision, which is screenings in our community. So I do think, I mean, a lot of programs have the Vision screenings. We call ours Vision, and the name of the other one, I think Sight Savers is the other one that's nationally very popular, where there are opportunities. I know, for example, at Pittsburgh, they have like the Gorilla Eye Clinic. So I would say if you look at a lot of places, they have opportunities for eye screenings, and that depend heavily on medical students. So look at what's available in your, at your school or, nearby centers. And then internationally, again, this would depend on your school, but we have had, for example, our Hopkins students go to Aravind Eye Hospital in Tamil Nadu in India to get exposure to either be doing a research project. We have faculty doing projects there. Like one of my recent students was doing a project about compliance with glaucoma eye drops in Aravind. So there's also organizations like Cure Blindness, which take students abroad. So I would say find your global health person, and if you don't have any at your institute, you can definitely look at programs with it. Like, for example, I don't know if many of you have heard of Jeff Tabin, but he's like this, he does so much work in Ethiopia, in Nepal, in Tanzania. So he's at Stanford. So, he's a great resource. And the American Academy of Ophthalmology also has a new global ophthalmology. This is the third summit they had, which is every summer. So, and they have a listserv for global ophthalmology. So, for anyone interested in that, find the people in the country at Moran or Stanford or Hopkins or, where these programs where they have these opportunities for students to go abroad.
Awesome, thank you.
All right, and Taylor?
So the question I had was that a lot of medical schools are increasingly turning to pass fail for either their first 2 years or for years afterward. My school is in this scenario. I'm at the University of Utah School of Medicine. I was just wondering if that is viewed as a disadvantage to applicants.
No. So yes, but by the way, University of Utah, I mentioned there's also this new growth of global ophthalmology fellowships. So Utah has one, Wills has one, Michigan has one. So those are the schools that again will help you in terms of global ophthalmology. But about the question about pass fail, no, because what now it's very clear when we get the applications who's pass fail and who's not. Now I would say most schools have a pass a tiered grading system for sub-I. So that's where you don't want to again get a pass on a sub-I because that's definitely a red flag. Minimum high pass and then shoot for honors. And usually now it's much more clear in terms of like they usually the dean's office when they do your dean's letter will make it very clear like what the grading system is for the school so that we're not going to be like, oh, your pass, they just got all passes and not know that it's just a pass fail system. So I have seen that it's easier to pick out the grading system in applications because the dean's office will say, pass fail only. And so that we know that that was just the way. So I would say, no, it's not a disadvantage, but do try to do well on the sub-I.
Perfect. Thank you.
Great. And next we have Drew.
Hi there. Thank you again for taking the time to talk to us today. My question is, I know obviously with applications, the interaction clinically is limited unless a rotation was done at your location. But when reviewing applications, what are some of the major qualities or attributes that you guys look at that make somebody stand out clinically as well as personally that would attest to you being a future great resident or ophthalmologist?
Yes, good question. I mean, I think clinical grades when available are important. And again, whether it be the sub-I, because you want to see, usually again, the step one or the step two we know is like a single score versus the longitudinal performance over, 4 weeks or so. So I think clinical grades are definitely important in ophthalmology. I think skills or characteristics that residency program directors look for in general are resilience because the residency the 4 years you'll be working hard no matter what program you go to generally. So we look for resilience. We also look for applicants who are team players because everybody wants residents who will sort of contribute to the camaraderie of the class. So and then I think any experiences, like for example, some residency program directors, we were just talking about this at Women Ophthalmology, but they like to, any work experience that you've had, let's say it's not specifically in, medicine, it's fine to put that down because they want to see sort of, again, grit and sort of the distance you traveled to get to where you are. And, we all have some distance traveled, some more than others, but, tell your story and sort of what makes you unique. The application, it's tough because, we read 650 of them approximately. So you kind of want to highlight what makes you unique because they do sort of all start to sound alike. So just anything that's most unique about you, make sure to kind of highlight in your application and talk about your passions and sort of, I do think a lot of, for me at Hopkins, I do get a lot of students saying that they definitely want to do academic ophthalmology. And so, I know sometimes they're, students are saying it because they want, they think that's what we want to hear. But I would say, go with your passion. And, usually there's like, it'll come out in the application in terms of what you've done to demonstrate, what you're putting down on paper too, in terms of if you say you're interested in global health, then, like you said, what I'll look for any global health experience or opportunities that you did on the application or sort of evidence to back up your statements as well.
And then we had a question in the chat from Annette Kaminaka. She's at Albany Medical College. She said that it was great to hear about the Hopkins STAR program and wondered if the research here with Hopkins would be with Hopkins or NEI faculty.
Yes, very good question. So we're not the only ones with the STAR program. There's several residency programs. I think NEI is going to fund 3. Stanford already had a research year. So you want to know what residency programs already had one, and then there'll be other programs that are either they might start next year just because of the, and that we're not getting notification of the funding till fall, but we're committed to it regardless of the funding or not. But for those of you really, and like Stanford again has the 1-year program where they do it's similar when they leave after PGY1. I heard Penn also has one that they do every other year. So you want to, for all the programs you work with, I think, faculty in the program. So at Hopkins, you'll be working with Hopkins faculty. And the reason we're doing it after the PGY1 year is so that you'll have your 3 months of ophthalmology, and you'll be more sophisticated in terms of doing research after some experience rather than, for example, directly out of med school. We also thought about doing it out of the PGY2 year, but that could be disruptive in terms of it being a busy clinical year, and you might lose momentum if you go out there. So right now we're starting with it after the PGY1 year, and I think it's great for those who are interested in academic careers because you can help find your research niche during that year that you can build upon as you go into potentially fellowship and start your academic career. Because the earlier you find what your research interest is, the more successful you'll be in academia, where you want to kind of be an expert in one specific area in terms of your publications, the talks you give, the grants you apply for.
All
I
right,
see a question about career.
Take one last question.
We have Mia, and then I'll answer Rasika's question real quick about career objective section. Advice for the career objective section is try to be as specific as possible, because like sometimes we'll get a real generic, like I want to see patients, teach, and so just be try to be as specific as possible with your examples, and then try not to repeat yourself. Like you have your autobiographical statement and your questions that SFH asks you, and then your career objectives. So you want to be like, you don't repeat your career objectives in the autobiographical statement or, any experiences. I've seen somewhere, I've seen like students that I've been reviewing, it's the same in both. So you want to use every opportunity to give us something new. And I would just say for the career objective section to be kind of specific and, maybe have a faculty quickly take a look at it, just because again, a lot of them start to sound the same. So you want to give it more specific examples. Like let's say you want to be a residency program director, don't be afraid to put it down there, or what's instead of just saying that you want to teach. So that's sort of an example of being more specific than just saying, I'm interested in being involved in education. And then Mia, we'll take your last question.
Hi, thank you so much for holding today's talk. My question is, what's one piece of advice that you wish you could go back and tell yourself, or what's one piece of advice that you tell students now that you wish that they knew early in their career, whether that be like in medical school or even in residency when attempting to be an ophthalmologist?
Yes, good question. I think one piece of advice would be to keep an open mind, so that I mentioned you might have a specific idea where your career will end up, but I would say that I actually didn't know I wanted to be a residency program director, but it's sort of my passion kind of led me to where I am. So kind of be open in terms of where your career might lead you, and find your true passion, because you definitely, no matter if you go into private practice or academics or industry, you want to follow your passion, because that will be what makes you successful. And then just knowing that there are different, I don't think I understood like how many different opportunities or choices there were when I was making my career choices. So I would say, keep an open mind, and then definitely talk to people along the way. I think a lot of you, the questions you're asking are great. So I feel like you're already sort of ahead of the game, but, don't be afraid to ask about all the different opportunities, so that, again, I've sort of, when I came back to Wilmer to be chief, I kind of knew that I would just stay on, and I didn't really look at other things. So just, I would say, keep an open mind, know all your opportunities, and then follow your passion. So.
All right. So with that, we would like to thank Dr. Woreta for her time and thorough advice. And we also really want to thank everyone for joining this meeting. So please
I forgot to answer one question for Annabelle. Why Cornea is the best field, Annabelle, because we're the structure to the rest of the eye. So sorry I didn't answer it, but we didn't talk much about that. But if anyone's interested in Cornea, please do contact me. And thank you, Aisha. Thank you all.
Thank you, Dr. Woreta. We love Cornea. But just a quick plug for our website. I put the link in the chat. You can use the website to check out the recordings of previous meetings, to join our mailing list. And also please follow us on Instagram. It's at Hopkins Ophthalmology VC. I will also put that in the chat, to keep an eye out for future monthly sessions and posts. So thank you, everyone, and have an incredible night. Thank you again, Dr. Woreta.
See everyone. Thank you.